Hello MS1s, welcome to our next to the last cardiovascular lesson, lecture number 16, Integrated Cardiovascular Responses. We're going to review some of the concepts we've already covered by considering how the cardiovascular system working together responds to stress. In the first short video, we'll explore the effects of gravity and exercise, and we'll begin with the Valsalva maneuver. In the second video, we'll consider the different forms of circulatory shock. And as usual, here are your learning outcomes for this lesson. You might have heard of the Valsalva maneuver. It is used as a bedside test of the baroreflex, and specifically the competency of the vagus nerve. It's performed by attempting to forcibly exhale against a closed glottis or while keeping the nose and mouth closed. Most of us perform this maneuver every day while straining to defecate, or when coughing, or when lifting a heavy weight. Forced expiration while preventing the air to escape creates an abnormally high pressure in the thorax, up to 80 millimeters mercury, and this evokes a characteristic sequence of cardiac reflexes. The chest X-ray on the left shows the silhouette, outlined in green, of the diaphragm and the heart in a person during a normal expiration. During a forced expiration against a closed glottis or a pinched nose, the diaphragm contracts upward strenuously, compressing the thoracic compartment and even the chambers of the heart, as shown in this chest X-ray. In addition, this high intrathoracic pressure strongly impedes venous return. And this provokes a characteristic sequence of contrasting baroreflexes that play out in 4 phases. Phase 1 marks the start of forced expiration. Intrathoracic pressure increases with a momentary rise in cardiac output and blood pressure as the thoracic aorta is compressed. Phase 2, this is the straining phase as venous return is impeded and the stroke volume reflected in the deflections of the pulse pressure and the cardiac output decline. And the resulting fall in mean arterial pressure triggers the baroreflex, and sympathetic drive causes a surge in tachycardia. Phase 3 occurs at the maneuver's release. Thoracic pressure is abruptly relieved, which brings us now to Phase 4, rebound. This reflects the resulting surge in venous return, stroke volume, cardiac output, and mean arterial pressure, which then activates the opposing baroreflex, an abrupt withdrawal of sympathetic tone, and a strong surge in parasympathetic vagal drive. And this causes a reflex bradycardia. So to summarize, during the forced expiration, we see a reflex tachycardia, and then on release, we see a rebound reflex bradycardia. So why is this important to the clinician? Well, to the cardiologist, the Valsalva maneuver can exaggerate heart murmurs and aid in the diagnosis of leaky or narrow valves. To the neurologist, the Valsalva can reveal impairment in some component of the baroreflex circuit. Do I expect you to know all of the phases of the Valsalva and their origin? No, but it will be important for you to know the following in preparation for cardiology in Block 7. Please be able to explain what the Valsalva maneuver is, what it is triggered by, and that it can be used as a bedside test of the baroreflex. And this is because it evokes a characteristic sympathetic tachycardia, and its release evokes a characteristic vagal bradycardia. Suppose your patient comes to you complaining of lightheadedness on standing, orthostatic hypotension. You ask your patient to exhale vigorously against a closed glottis or a closed mouth and nose. But just a few moments later, the patient faints. What happened? Well, the forced expiration, high intrathoracic pressure, impeded venous return, preload, stroke volume, and mean arterial pressure. In this patient, with autonomic dysfunction, there was an inadequate sympathetic augmentation necessary to preserve mean arterial pressure and perfusion of the critical organs, like the brain. Mean arterial pressure continues to fall until the cerebral ischemia causes the patient to faint. Syncope. A nice example of how the Valsalva can be used as a bedside test of autonomic dysfunction. So what is syncope? It is formally defined as the transient loss of consciousness accompanied by loss of postural tone, and the falling down part can cause serious injury. What should you do if you see someone faint? Well, the best thing to do is to first make sure they're breathing, then lift their legs. This will move about a liter of blood in the leg veins to drain into the thoracic compartment, where it is immediately available to improve preload, stroke volume, and arterial pressure. We'll learn more about this in a moment. Several years ago, I was watching TV and President Obama was giving a speech, and I saw this young woman in the background with this look on her face, and I knew what was happening. That look has vasovagal syncope written all over it. Vasovagal syncope. It is the most common form of fainting. The vaso prefix refers to the fact that fainting arises from a sudden withdrawal of sympathetic vascular tone, and this results in an abrupt loss of systemic vascular resistance due to arteriolar vasodilation, along with a loss of central venous pressure preload due to venodilation. And the vagal portion of the term refers to the abrupt reduction in cardiac output due to a lapse in cardiac preload and contractility, but the vagally mediated reduction in heart rate. The vaso and vagal responses conspire together to exert a double whammy on arterial pressure, simultaneously reducing both SVR and cardiac output. As the arterial pressure drops, perfusion of the brain lapses, and before losing consciousness, the individual often experiences a so-called prodromal syndrome that includes lightheadedness, nausea, weakness, the feeling of being extremely hot, and many of us have experienced this before. Several common conditions can set the stage for vasovagal syncope. A reduction in blood volume through hemorrhage, sweating, or peripheral venous pooling associated with prolonged standing. Painful or unpleasant stimuli, such as giving blood. Remember that certain thoughts originating in the cerebral cortex can have a powerful negative pressor effect on the medullary cardiovascular center. Prolonged exposure to heat, which is often associated with sweating. Extremes of emotion. Hunger, underlying nausea, vomiting, which can contribute to volume depletion. Not too long ago, we had a CBL case of an orchestra conductor who was experiencing frequent episodes of fainting, but only while performing. It turned out that this orchestra conductor was taking a diuretic drug for his hypertension, and no doubt, during the performance, he was anxious, sweating under the hot lights, and standing for prolonged periods. So many things conspired together to set the stage for vasovagal syncope. How about this classic picture? Standing for long periods of time at attention in a heavy wool coat and furry hat on a hot day is enough to cause severe peripheral venous pooling. Now, when the person loses consciousness and falls, the inhibitory effect of gravity on venous return, made worse by venodilation, is eliminated, and the resulting improvement in ventricular preload helps rapidly restore cardiac output and mean arterial pressure perfusion to the brain. And within 10 or 15 seconds of vasovagal syncope, the individual usually regains consciousness. It is now believed that the Basal-Gerish reflex, which results from excessive contortion of a hypercontractile and underfilled left ventricle, contributes importantly to vasovagal syncope. The theory is that excessive peripheral pooling of venous blood, or dehydration, results in decreased central venous pressure and a reflex increase in sympathetic nerve activity through the barrel reflex. The problem arises when the underfilled ventricle becomes hypercontractile under sympathetic bombardment. As it contracts vigorously around an underfilled chamber, the ventricular wall contorts severely and abnormally. This unusual twisting of the wall activates the cardiopulmonary volume receptors, the so-called unmyelinated C fibers, and this paradoxically increases inhibitory traffic to the brainstem. Sympathetic output to the heart and vasculature is then abruptly withdrawn, leading to vasodilation, the vasodepressor syndrome, and vagal input to the heart and viscera is increased, causing sudden bradycardia and nausea. So how might we interfere with this cascade of events in the Basal-Gerish reflex? Well, negative inotropic agents like beta-1 blockers are sometimes prescribed at low dose to prevent the exaggerated cardiac inotropy that triggers the reflex in the first place. Second, the patient who is prone to vasovagal syncope is instructed to drink plenty of fluid every day, and when they begin to experience a prodromal syndrome, they are instructed to immediately lie down. And this might prevent a catastrophic fall and injury to the head. Okay, now let's consider the effect of gravity on blood pressure. So far, we have portrayed blood pressure as solely the pressure generated by the contracting ventricle. But blood pressure is actually contributed by two forces. In addition to the so-called hemodynamic pressure, PA, generated by the pumping action of the heart, we must also factor in the hydrostatic pressure contributed by the weight of blood under the influence of gravity. Recall from college physics that the hydrostatic pressure can be calculated from the equation rho times g times h, where rho is the density of the fluid, in this case blood. It's a little over 1,000 kilograms per cubic meter. G is the all-important gravitational constant, 9.81 meters per second squared, and h is the height of the column of fluid in meters. The effect of gravity is a real challenge to the circulation in humans, where most of the blood volume, 70%, is located below the heart. Gravity pulls the blood to the lower or so-called dependent extremities, not just the legs, but also the lower arms below the heart. So the effect of gravity is minimized when we lay down and maximized when we stand up, a term called orthostasis. Quadrupeds, like dogs, are not faced with this challenge because most of their blood, 70%, is located near the level of the heart. So consider the cardiovascular effects of standing on the added hydrostatic pressure at different parts of the circulation. Consider the effects of gravity and vascular pressures and volumes on this guy's cardiovascular system. This giraffe's brain is 2.7 meters above his heart. So to overcome gravity and maintain blood flow to the brain, the giraffe's heart must generate an extra hydrostatic pressure, which we can calculate from rho GH. If we plug in 2.7 meters into the equation rho GH, we come up with an extra 200 millimeters mercury pressure required by the heart to perfuse the brain. So the giraffe's heart must generate twice the normal pressure for a large mammal, 200 millimeters mercury, in order to overcome the effect of gravity and perfuse the brain 2.7 meters above the heart. It can do this with two adaptations. First, a very large muscular heart and a very rapid resting heart rate, 150 beats per minute. Think about what happens when the giraffe lowers its head to drink from a pond. The distance from the heart to the ground is again about 2.7 meters. So an extra 200 millimeters of hydrostatic pressure would be exerted on the brain. Were it not for the complex pressure regulation system called the rete mirabile in the upper neck of the giraffe, which prevents excess pressure from reaching the brain. The lower limbs of the giraffe are also under great hydrostatic pressure due to the weight of blood pressing down on them. Peripheral edema is prevented by a thick sheath of skin surrounding the giraffe's lower limbs. In other words, giraffes have built-in TED hose or a pilot's G-suit as standard equipment from birth. No varicose veins or pedal edema in these beauties. By the way, does the hydrostatic pressure contributed by gravity affect perfusion pressure through the feet? No, and this is because gravity has the same effect on the arterial and venous pressures. So the pressure difference, the perfusion pressure, is really a function only of the hydrodynamic action of the heart. Let's consider this in humans. Posture has a large effect on vascular pressures and volumes. When we lie down, the blood pressures in the feet and scalp are nearly equal. The effect of gravity is the same at the same height. Notice that the distension of the vein and the artery are about the same, even though the artery is subjected to a much greater hydrodynamic pressure, 95 versus 5. Why? Because the wall of the vein is much more compliant, distensible. When we stand up, the vessels in the ankle have to support the weight of the long vertical column of blood extending from the foot to the heart. How much vertical pressure will the hydrostatic column add to the intravascular pressures in the ankle? Well, we can calculate it with that simple formula rho GH, and that formula will tell us that a 109 centimeter column of blood will add about 80 millimeters mercury to the vessels of the ankle. So we must add the hydrostatic pressure to the hydrodynamic pressure, and we get an arterial pressure of 175 torr and a venous pressure of 85 torr. Notice that the AV pressure gradient, or the perfusion pressure, remains 90 millimeters mercury. So gravity does not change the perfusion pressure through the feet because it has the same effect on arterial and venous sides. The gradient doesn't change. but the added hydrostatic pressures in the lower extremities do have important effects. Now the veins in the lower legs and the lower arms distend under the added hydrostatic pressures. So the important message here is that hydrostatic pressure acts to distend dependent vessels, especially veins, because they are compliant. And this will cause peripheral venous pooling when we stand up. You can see venous pooling when you lower your arm. Try it right now. Lower your hands, wait about 10 seconds, and observe the distension on the veins of the back of your hand. Now raise your arms slowly while watching the distension of the veins, and take note of where that distension disappears. In health, the distension will disappear when your hand is about 10 to 15 centimeters above your heart, and that reflects central venous pressure. In patients that have lost a lot of blood or are dehydrated, the distension will disappear at lower levels. On the other hand, in patients that have high central venous pressure, for example, patients in heart failure with volume overload, this distension might persist even when they raise their arms well above their heart. So this postural displacement of venous blood when we arise from a supine position challenges the cardiovascular system. Many times each day we arise from a recumbent or supine position to a standing position, and this is called orthostasis. Under the influence of gravity, as we stand, there is a displacement of venous blood from the thorax near the heart to the lower extremities, away from the heart. When we stand up, about 500 extra milliliters of blood leaves the thoracic compartment and accumulates in the veins of the legs and feet, in spite of vasomotor compensations ongoing. What are the consequences of this venous pooling? Well, most importantly, this postural displacement of venous blood lowers central venous pressure, preload. Cardiac output momentarily decreases by about 40%. And in patients whose baroreflex is impaired or blunted, this can lead to postural hypotension. Fortunately, our body has several mechanisms that quickly compensate for this postural displacement of venous blood and to preserve central venous pressure. Let's review the cardiovascular effects of standing. When we arise from a supine position, there is a postural displacement of blood from the central venous compartment to the peripheral veins. It amounts to an extra 500 or 600 milliliters of blood in spite of ongoing venoconstriction. The displacement of blood from the thoracic compartment lowers central venous pressure, preload, and as a consequence, there's a reduction in stroke volume, cardiac output, and mean arterial pressure. This will activate the baroreflex, and we will see all of the compensations that we covered in the lecture on arterial blood pressure regulation. A sympathetically driven increase in heart rate, contractility, sympathetic venoconstriction to offset the peripheral venous pooling, sympathetic vasoconstriction, and a compensatory increase in systemic vascular resistance, all of which stabilize central venous pressure, preload, mean arterial pressure. In addition, as we stand up, the venous valves break the hydrostatic column into short segments and mitigate the effect of gravity, and the skeletal muscle pump milks venous blood toward the heart, and together with the thoraco-abdominal respiratory pump, venous return is partially restored. If these mechanisms should fail, the result is postural hypotension, a lapse in venous return on standing with inadequate perfusion of the brain that causes dizziness or even loss of consciousness. It is caused by an unopposed gravitational shift in thoracic blood to the lower extremities and a reduction in central venous pressure, preload. What are the precipitating factors? Hypovolumia, prolonged standing, venous valve insufficiency. And as we've just seen, the principal defenses are the baroreflex, the skeletal muscle pump activity, and the thoraco-abdominal pump activity. Okay, to finish off, I'd like to highlight just a few important concepts on the cardiovascular responses to exercise. And a more detailed review of exercise will be presented by Dr. White in 3 lectures in the last week of Block 2. This slide probably looks familiar. Strenuous exercise challenges all parts of the cardiovascular system to perform up to the limits of their design. Blood flow to the working muscle must increase up to 40-fold to meet their metabolic demands, so cardiac output must be increased. Blood flow through the lungs and gas exchange must increase to blow off more CO2 and to replace more oxygen. And lots of extra heat must be removed from the skin. In healthy young adults like yourself, cardiac output can increase from about 5 liters per minute to a maximum of between 20 and 25 liters per minute. In highly conditioned athletes, the heart is capable of up to 40 liters per minute. And because the hard-working skeletal muscles demand more flow, they can steal away more and more of the cardiac output. In strenuous exercise, up to 90% of the cardiac output may be diverted to the working muscles. And this comes, as we've seen, at the expense of flow to the skin, the gut, and the kidneys. So think about the mechanisms responsible for this redistribution of blood flow. Let's perform an experiment. We place a test subject on an exercise bicycle, and we ask them to increase their rate of pedaling stepwise from very low to maximal. In other words, we gradually increase the amount of work performed. As you might expect, the rate at which the body consumes oxygen will increase in linear proportion to the amount of work performed. And with increasingly vigorous exercise, the skeletal muscles will demand greater blood flow, and the local metabolic vasodilation, summed up over all of the working skeletal muscles, will result in a large decline in systemic vascular resistance. But in spite of the drop in SVR, mean arterial pressure will remain remarkably constant because of the barrel reflex. The drop in SVR is matched by a proportional increase in cardiac output. How was the output of the heart increased? Well, the baroreceptors sense a momentary drop in arterial pressure, and they instructed the brain to withdraw parasympathetic inhibition and augment sympathetic drive. This produced increasing vigor in ventricular contraction and stroke volume, along with an increase in heart rate. And this accounts for the increase in cardiac output. Note that systolic blood pressure increases, and this reflects the increasing hypercontractility of the heart with a larger and more vigorous stroke volume. Exercise capacity is generally limited by the functional capacity of the cardiovascular system, especially the heart's capacity to pump blood and the vasculature's ability to return it. Exercise capacity is also limited by the pain and exhaustion associated with the acidification of muscle tissues with CO2 and lactic acid. Let's think about the increase in heart rate with exercise. Remember, at rest, the heart rate is dominated by vagal parasympathetic input. The intrinsic firing rate of the SA node pacemaker cells is about 100, but dominant vagal input at rest slows down the pacemaker to about 60 or 70. So notice that at rest, there is very little sympathetic influence on heart rate. As we begin to exercise, heart rate is increased by withdrawing vagal tone. Heart rate will increase up to about 100 per minute, and again, this is caused almost entirely by the withdrawal of vagal tone. With more strenuous exercise, the heart rate will increase further, and this reflects sympathetic augmentation. And this explains why a beta-1 adrenergic blocker, which is a frontline drug for ischemic heart disease and congestive heart failure, have a minimal effect on resting heart rate, which is dominated by vagal influence. Their main effect is on exertional increases in heart rate due to increasing sympathetic input. This is an important clinical implication. It's often seen on the Step 1 exam. Beta-1 blockers have a minimal effect on resting heart rate, and this explains it. This graph plots the heart rate as a function of oxygen consumption, workload, or exercise in a normal individual or in an individual with a diseased heart. In this case, it's heart failure, but it could also be mitral stenosis, and in a well-conditioned athlete. The first thing to note is that resting heart rate is lowest in the athlete and highest in the patient with impaired cardiovascular function. In each of these individuals, the heart must develop an arterial pressure that is sufficient to perfuse the tissues and satisfy the baroreceptors. The athlete's heart can eject a much higher stroke volume and therefore can develop an adequate blood pressure at a lower heart rate. In contrast, the patient with the failing heart develops a low stroke volume. So in order to develop an adequate cardiac output, their heart rate must be higher. The next thing to note is that at a similar heart rate, let's look at 100 beats per minute, the athlete is able to do far more exercise than the normal individual, and the healthy, normal, non-athlete is able to do far more work than the patient in heart failure. And the third thing to notice is that in all three individuals, the maximal heart rate is similar, about 190 to 200 beats per minute, but this will vary somewhat with age. So we can conclude that maximal heart rate is not the limiting factor for these differences in exercise capacity. Let's model these cardiovascular adjustments with exercise on a PV loop. When we exercise, the ventricular function curve, the Frank-Starling length-tension relationship, is shifted upward and to the left. This reflects an increase in cardiac contractility driven by sympathetic augmentation. and on the next beat, the PV loop will intersect the ventricular function curve at a lower ventricular volume, resulting in a lower end systolic volume, residual volume, and a greater stroke volume. So during exercise, the Frank-Starling curve is shifted due to sympathetic augmentation, and ESV is decreased because of this greater contractility. So how is the end diastolic volume maintained in exercise? Sympathetic venoconstriction to mobilize blood from the periphery, increased skeletal muscle pump activity, increased respiratory pump activity, all working together to increase venous return and maintain EDV on each beat. And finally, let's define cardiac reserve, which is a topic we'll hear more about. The degree to which the cardiac output can increase to meet the demands of exercise is called the cardiac reserve, and 0 represents the cardiac output at rest. In a normal, healthy adult, the cardiac reserve is about 400%. In a well-trained athlete, the reserve can be as high as 600%, but it may be only 200% or less in elderly people or people with cardiovascular disease. For example, when the coronary arteries become occluded with atherosclerotic plaques and can no longer deliver enough blood to the myocardium, in other words, ischemic heart disease, there may be little or even no cardiac reserve. In these cases, or in severe myocardial infarction or valve disease, the heart may struggle to maintain a sufficient peripheral flow even under resting conditions. Well, as I noted in the intro slide, I had planned to include an overview of circulatory shock, but we've run out of time, and I will create an online video on this topic in place of Dr. Bolger's scheduled session on October 30th. So we'll devote a separate short video on shock. Well, that concludes Lecture 16. Thank you so much for your attention.